Okay, good morning. Thank you very much, Catherine, and I'm delighted to contribute to this important symposium on psoriasis and multimorbidity and contribute a little bit from a rheumatology perspective. By the way, I've got no conflicts of interest for this presentation. Well, psoriasis is a very common feature of this group of conditions that we label as spondyloarthritis. Most obviously with psoriatic arthritis, but also psoriasis is more common than in the normal population and these other conditions, including, for instance, ankylosing spondylitis and indeed enteropathic arthritis. Other common features are inflammation of the spine or spondylitis, anterior uveitis, enthesitis, inflammatory bowel disease, and one aspect that is getting increasing recognition is the presence of metabolic syndrome or obesity that I will return to and will be addressed by one of the other speakers this morning as well. It was Werner Wright, later joined by John Moll, whose landmark studies more than 50 years ago put psoriatic arthritis firmly on the map. They distinguished it from rheumatoid arthritis, and they described this intriguing relationship between psoriatic nail disease and distal interphalangeal joint involvement. They also reported some of the characteristic radiological features of psoriatic arthritis, such as the pattern of erosive disease, note the bony swelling around the joint here, and the presence of sacroiliitis. They may have done the condition some disservice by saying it was less severe than rheumatoid arthritis, which is a notion that today I think we would debate. And they described 5 classical subgroups of psoriatic arthritis seen here. They gave prominence to a group with oligoarthritis or 4 or less joints involved, although we now know a lot of these patients do evolve into a more polyarticular form, albeit it's less symmetrical than rheumatoid arthritis, for instance. Another group are those with predominantly DIP joint disease, often with nail disease, and a less common form, those patients who have quite severe osteolysis of their joints and develop severe destructive arthritis mutilans. And then finally, spondylitis, which is similar but not identical to ankylosing spondylitis. But with knowledge now that the primary site of inflammation in psoriatic arthritis is not necessarily in the joint synovium, but rather where the tendon inserts into the margin of the joint, that is enthesitis, we need to add this group to the subgroups. Indeed, the rheumatologists are taking the nail on as their own territory, given its close proximity and contiguity with enthesial components. And the studies by McGonigal and others have nicely shown this and really help explain the observations of Wright more than half a century ago of this association between nail disease and joint disease. So enthesitis may be manifest as swelling of an Achilles tendon, or indeed the other characteristic feature of psoriatic arthritis when an entire digit becomes inflamed, a sausage digit or dactylitis, seen here as an inflamed finger or indeed an inflamed toe. And you may have patients with psoriasis without obvious psoriatic arthritis, and if they have nail disease, they're more likely to have enthesitis or enthesopathy at distant sites, as shown here in this study using ultrasound scanning as a score, showing that the score is higher in those with nail disease compared to those without nail disease and normal controls. So you may wonder that the diagnosis of psoriatic arthritis is a challenge given the very diverse aspects of the disease and the different domains affected, from skin psoriasis to nail disease to peripheral arthritis, spondylitis, and enthesopathy. There are clues that a rheumatologist can use to make a clinical diagnosis of psoriatic arthritis and distinguish it, for instance, from rheumatoid arthritis. I've mentioned a number of these already today. One point to bear in mind is that psoriatic arthritis is usually negative for rheumatoid factor and lacks autoantibodies to citrin-related peptides, or ACPA, which is useful in some ways, but less useful in that psoriatic arthritis lacks a specific diagnostic biomarker. So the development of the CASPA criteria for psoriatic arthritis was a welcome addition and is widely used clinically, although bear in mind these are classification criteria and not diagnostic criteria. But a patient may be said to have psoriatic arthritis if, on a background of an inflammatory disease affecting joints, spine, or enthesis, he or she has 3 or more points from this list here. Now, although psoriasis and nail disease are given prominence, obviously, it's also important to note that a patient may be diagnosed without them being present if they have these 3 other features here. So those patients with, say, typical joint disease but may not as yet have developed psoriasis. However, given the resources needed to make a diagnosis, the blood tests, x-rays, the need to take an adequate history, you may wonder that it's more appropriate for the dermatologist just to be aware of a possibility of psoriatic arthritis rather than to make a specific diagnosis. And that's important because psoriasis precedes psoriatic arthritis in the majority of cases. And this is one of our own studies where we've used a large UK clinical practice health data record and also our own cohort of psoriatic arthritis in Bath. And the median interval between psoriasis and the onset of psoriatic arthritis is somewhere between 8 to 9 years, respectively. So there's a massive window of opportunity here for early diagnosis of an important inflammatory joint disease. Now, how important is it to make an early diagnosis? Well, we know that in dermatology clinics there's a high prevalence of undiagnosed psoriatic arthritis. We also know from studies that a delay in diagnosis may be associated with a poor outcome, and I've listed some of those studies here, including one of our own. But most of these studies are retrospective and do have selection and recall bias. Nonetheless, the UK watchdog NICE does recommend annual screening for patients in primary care on treatment for psoriasis. However, this is not done, and there are lots of patients with psoriasis not attending healthcare or indeed not on treatment for their psoriasis. So whilst we have tackled this question head on in a recently completed NIHR randomized clinical trial, I have to say at this point in time, this question of early detection and the importance is unanswered. But if we do believe that screening is important, there are a number of tools available for screening for psoriatic arthritis, and I've listed some of those here. In truth, in practice, they all perform rather similarly, according to this meta-analysis and systematic review listed here. One which we tend to use, which is relatively simple and advocated by NICE, is the PEST questionnaire that I've listed here. That is relatively straightforward to administer and comes with a helpful, cheerful mannequin as well. Next question, who should be screened? Well, I think there's a good argument for targeting screening to those patients who are at increased risk of psoriatic arthritis. And I've listed what I think there's the most evidence for these factors listed here: family history, history of uveitis, nail psoriasis, high BMI, which I will return to in a moment. And who should screen? Well, there's arguments for screening in primary care, certainly in dermatology, perhaps in pharmacy, or maybe even the patient, him or herself. All of these need consideration. Are there particular populations at risk of developing psoriatic arthritis? Well, most obviously psoriasis, but on the background of psoriasis, note that the risk is even higher with nail disease and probably with severity of psoriasis as well, data that I'm not going to review now. But it's worth noting as well that if your patient with psoriasis has uveitis, they are far more likely to develop psoriatic arthritis than the general population. We've been interested in the role of lifestyle factors and their contribution to the risk of developing psoriatic arthritis. Here is some of the background, important background papers listed here for obesity, alcohol, and smoking. So we've used this large UK primary care health record of 15 million people, which has given us about a 90,000 incident cases of psoriasis, of whom 1,409 developed psoriatic arthritis in this 16-year window. And we've looked at these factors, smoking, alcohol, and BMI, as risk factors. And the data is summarized really on this slide. And the important points to note are that with an increasing BMI, the odds ratio of developing psoriatic arthritis increases such that those with a BMI of greater than 35 are at highest risk of developing PSA. Note that in this study, and similar to other studies, we found no association with smoking. This is after confounding factors have been adjusted for. Interestingly, we also had the chance of looking at a change in BMI over a 10-year period and what this did to your risk of developing psoriatic arthritis. This is summarized here, and that if over that 10-year period you increase your BMI, there's a linear increase in risk of developing psoriatic arthritis, seen here in the red, whereas conversely, if you lose BMI over that 10-year period, your risk diminishes. And to show you a case in point here, with a BMI of 30 at baseline, but managed to reduce it to 25, a loss of 5 units over a 10-year period, this is associated with about a 15% lessening of the risk of developing psoriatic arthritis. So although this doesn't demonstrate causality, it may give your overweight psoriasis patients some incentive to lose weight, and that they're less likely to develop psoriatic arthritis, along with other obvious health benefits. As this is a session on multimorbidity, I can't resist showing you some data also from the CPRD, where we've looked in this case at almost 7,000 patients, this time with incident psoriatic arthritis, and 1 to 4 matched them with a psoriasis cohort and with the general population, and looked at these comorbidities listed here. And results are summarized on this slide, and that patients with psoriatic arthritis are 2 to 4 times more likely to develop uveitis than the general population, 3 to 4 more times more likely to develop Crohn's disease, and no increased risk of ulcerative colitis, at least in this data set. Also more likely to develop type 2 diabetes, and this is when important confounding factors are adjusted for, such as obesity. And finally, more likely to develop cardiovascular disease than the general population or psoriasis controls, although in the latter case, this did not quite reach significance. So even though we were only able to follow these patients for a relatively short duration, even in this time, I hope I can convince you that the presence of psoriatic arthritis comes with substantial additional multimorbidity. And then my final slide, I'm just going to touch on the importance of phenotypes when it comes to considering therapy. And you'll be pleased to know I'm not going to talk you in detail through this particular slide. It is the latest International GRAPPA group updated treatment recommendations for psoriatic arthritis. Note that all the phenotypes or subgroups I've described today are listed here with the treatment recommendations. Now, although there's a lot of commonality, and you'll recognize these agents along here, there are some nuances in terms of the treatment recommendations in different phenotypes. For instance, axial disease, the options are far less for a choice of therapy that's been proven to be effective. The recommendations don't address the appropriate sequencing of effective therapies, but there are some light touch position statements on aspects such as biosimilars and tapering therapy, and also some recommendations for treatment in the presence of comorbidities. So I'm going to finish there, just to acknowledge the NIH program grant that funded some of the work I've mentioned and my collaborators on this program. Thank you very much.
Very much, Neil, for a great talk. Are there any questions? Do we all feel that we know how to pick up psoriatic arthritis? Are we all doing screening? Or think with screening?
I think it's very important for us as dermatologists today to get from your talk is that we need to screen our patients. PES questionnaire is really helpful, definitely. But apart from that, for example, personally, I had the luck to be trained in a clinic where we were doing joint clinics with rheumatologists. So I was taught how to do a rheumatology examination. I was taught when to order an ultrasound, when to order my x-rays, my MRIs. So I had my patient prepared to see the rheumatologist, and there was no delay. So I think for us it's really important to make sure that we have a very good connection with our rheumatology departments. Joint clinics are really, really important, and we need your knowledge and your teaching as dermatologists so as to be able to detect our patients with psoriatic arthritis earlier. Thank you.
Okay, yeah, thank you very much. I think that's, and certainly joint clinics, particularly for those patients who have severe impact from both sort of conditions, the psoriasis and arthritis, and in terms of treatment decisions for biologics. I think your setup sounds brilliant. I don't think one would expect the normal, routine dermatologist to have the ultrasound next door to be able to scan, but just to be aware of the presence of psoriatic arthritis and maybe use of one of those screening tools that I've mentioned.
Just to pick up on the IL-17 and the axial arthritis and Crohn's, is there any difference in terms of risk of inflammatory bowel disease in the different psoriatic phenotypes? Is there a greater risk with the axial arthropathies, for example?
There probably is, Catherine, but it doesn't mean that one shouldn't use, IL-17 inhibition in ankylosing spondylitis, given that that and anti-TNF are really the only two proven sort of biologics for ankylosing spondylitis. But one should be aware of a possibility.
I just want to empower dermatologists to treat PSA, because in my community, I think there's only one rheumatologist who knows more about PSA than I do. And we see the patients more commonly than rheumatology, I think. They're coming to us for their skin disease. We're seeing early PSA. All the drugs that we use are often approved for PSA as well. So sometimes I hear dermatologists say, well, they have PSA, that's not me, but it really is us. I think for the majority of patients, it's us, and we can do it well, I think.
Okay. You're doing rheumatology out of a job, so...
Perhaps that's something to pick up,
I
actually.
think you're absolutely right. There's a spectrum, I think, of expertise and interest, and certainly dermatologists with an interest in psoriatic arthritis are very able, to make treatment recommendations.
Okay. One more question, then we'll move on. Thank you.
Thank you one more time for an amazing report. I just interested, of course, it's very good when we have previously some patients with a manifestation on the skin, but sometimes in our practice we met patients that have pitted nails or some other typical changes for psoriasis, and just beginning pain in joints, in distal joints, in spondyle region also, and the changes on X-ray, they are not so much clear and typical on that stage. In that case, how we must to manage that patients, and from which point we must to start, how often we must to see them to put the diagnosis of the psoriatic arthritis, because sometimes we have previously we have changes in nails and some beginning pain in joints, but not any manifestation of the skin. Thank you.
Yes, no, thank you. Thank you. I think the presence of nail disease may point to a sort of an enthesopathy, related to symptoms of pain and tenderness, but they do need appropriate sort of evaluation with blood tests and x-rays if there is a chance of psoriatic arthritis. I hope I've understood your question correctly.
So just, distinguishing between the pain of nail disease and arthritis. Is that your question? So at the stage where you have nail disease and pain, but no other features, and how do you make the diagnosis?
Just a careful evaluation, really. There's nothing, a good history of inflammatory disease, because pain could mean a number of different things. It could be osteoarthritis, fibromyalgia. So it has to be evidence of an inflammation, joint enthesial or spinal inflammation to make a diagnosis.
Okay, thank you. Thank you very much, Neil. Thank you.